Good morning, good afternoon, everyone. I'm really delighted to welcome you here today for this Partnership for Maternal, Newborn and Child Health webinar on funding the future, effective financing models to advance women's, children's and adolescents' health in times of crisis. There is clearly an overwhelming interest in this discussion because unlike any other discussions that we have been in recent times, we have over 800 people registered for this conversation. And I'm really hoping the platform does hold true as multiple people join through the conversation. And quite rightly so, because colleagues, we stand at a pivotal moment. Deep cuts to official development assistance risk undoing decades of progress in global health. Major donors announced cuts to their ODA for 2025 to 27 period. Together, these cuts accounted for nearly 3/4 of total ODA in 2024, making these reductions a major shock to international cooperation. This reality is underscored the urgent need to transition towards stronger domestic resource mobilization, ensuring that countries can sustain and expand essential health services. At a time when multilateralism is under great strain, it is the world's most vulnerable, especially women and children in low and middle income countries, who will be bearing the heaviest burden if innovative and sustainable financing is not secured. We know this by just looking backwards the last few years. A recent analysis of previous aid sanctions from 1990 to 2019 revealed their devastating impact on maternal, newborn, and child mortality. Over this period, aid cuts were associated with a yearly increase of maternal mortality by 6% and similar increase in child mortality by 4%. And the projections for the future are even more stark. Evidence points to a devastating reality. An estimated 14 million additional preventable deaths are projected worldwide by 2030, of which 4.5 million will be those of children under the age of 5. Colleagues, this is not a policy failure only. It's a moral catastrophe in making, particularly for those already vulnerable, including women and children living in humanitarian crises and fragile setting. In parallel, we are also seeing another trend, and that is of domestic spending on health, which is declining in many low and middle income setting countries. Out-of-pocket expenses therefore continue to be the primary source of funding in 30 low and middle income settings. This reliance on direct payments by individuals and families exacerbate financial hardships and deepens poverty for those who are already struggling. A single medical emergency can push the entire family into destitution. However, there is hope because evidence does point to the importance of budget advocacy and financing models, putting women's, children's, and adolescent health at the center. The newly released evidence from the Lancet Commission on Investing in Health highlights the critical importance of prioritizing maternal, newborn, and child health in national budget plans to achieve major impact on mortality reduction and also furthermore for economies overall. In times of adversity, we need to think and act differently. Last week, at the Global Leaders Network webinar, we provided insights into how initiatives are being developed and implemented to advance domestic resource mobilization. And we will have some crossover of that conversation into our conversation today as well. A key lesson from that discussion is that maximizing impact will require documenting good practices, reducing fragmented efforts, and ensuring budget allocations that prioritize health of women, children, and adolescents. And today, we will build on these important lessons. I'm particularly proud of today's webinar and all our honorable speakers, which bring together an influential set of policymakers, health leaders, donors, and experts dedicated to the health and well-being of women, children, and adolescents. Today, we will explore the critical need for innovative financing and partnership building to enhance domestic financing and support greater financial accountability. By learning from what works and how, we can foster evidence-based solutions that attract stronger financing and effectively address the differential needs in different national contexts. A couple of quick housekeeping rules before I invite my first speaker today. First, please do take time to introduce yourself in the chat and keep an eye out for links that are being posted throughout the webinar because we hope to share with you different pieces of evidence that can enrich your own advocacy efforts where you live and work. Second, we will also have Q&A session on the program and interspersed through the conversation we will have this morning and through each of the segment, we will have questions to the panelists and we will be consolidating your comments and putting it back to them. So let me now begin with the first session, which is on policy, and invite a dear friend, Dr. Solomon Warku, Senior Advisor from the Ministry of Health, Ethiopia, to take the floor for his remarks. Ethiopia is an active member of the Global Leaders Network. And in the conversation last week, Honorable Minister Daba made some very strong remarks and highlighted how Ethiopia is implementing its commitment to ensure long-term financial resources to address malnutrition as a key challenge to the health of women, children, and adolescents. Dr. Woku, we look forward to your valuable insights on Ethiopia's leadership to advance women, children, and adolescents' health. Over to you.
Thank you so much, Rajat. Good morning, good afternoon for everybody who's attending this session across the globe. Thank you for having me in this very important session to talk about the financing for SRH services. I'm here on behalf of Minister Makdas, who's sending her greetings to the entire audience here and sending her apologies for not making it for this such important event. As you all know, healthcare financing including for women, children, and adolescent health has become very important, and conversation is happening everywhere right now. It has become a very hot subject for obvious reasons that you all know. Just last week alone, there is a summit on a joint AU CARICOM meeting. One of the agenda was healthcare financing for the HRH and as well as for RNMCH. So this shows us that how important this subject is right now for all of us here. So in this webinar, I'm tasked to talk about Ethiopia's experience, to reflect on Ethiopian experience and on how to implement innovative financing for women, children, and adolescents. So the country has actually pursued strategic directions to institutionalize sustainable financing mechanism for women, children, and adolescent health. For this, number one, we have a clear strategy document. We have a healthcare financing strategy, and we've made women, adolescent, children health as an essential component of health service package in the country. It all begins from here. Before talking about the finance, the country has positioned RNMCH, women, children, and adolescent here at the center of health service package. We made it essential. So once you make a service essential at the heart of healthcare services, then negotiating and financing would be much easier. So as you might remember, long before there is a budget cut on ODA cut, we begin to see a decline in funding for family planning services, as you all know. So it's not something new, but we begin to see in the turn of around 2020, entirely the family planning budget has been going down. So Ethiopia has taken some serious steps to address this. The first one is through closely working with the Minister of Finance, Minister of Health managed to secure a dedicated budget line for RH commodities. That is a very bold and essential step, showing how this government is committed to what we do at the Ministry of Health. To this, we have developed what is called a costed implementation plan for family planning. This makes regional governments as well to allocate a certain amount of money for RH services, including family planning. That's the first thing. The second is co-financing. Initially we began co-financing through Family Planning Compact, which is the government has to match equal amount of money to the donor commitment. So through that lesson, through the lesson from Family Planning Compact, Recently, we managed to raise close to 100 million USD for our NMCH compact because of the lesson that we've drawn from family planning compact. This hugely shows two important things. Number one, the political willingness, and number two is the leadership commitment. So what I'm trying to say here is, in the long run, the government is going to take over and fully fund these essential RNMCH services. Another thing probably worth mentioning is there is a progressive increment in budget for health. So if there is an increase in budget share for health, that means that RNMCH or women, children, adolescent health would also get its own share. So that from the big pie, we're gonna get our share as well. So recently as well, this is also worth sharing for this crowd. Through Innovate and Pilot and Scale, we have introduced what is called a social business model, which is through generating revenue from the private sector, will reinvest the profit to finance women, children, and adolescent health care. And this is essential for two reasons. Number one, it's a very good sustainable alternative means, because the revenue generated would ensure long-term operation without donor reliance. And two, is it also ensures equity, because we target marginalized populations which are left out and we actually needed access for our NMCH services. And before my final remarks, I would like to make this important point. This is time for us to be able to rethink how we engage donors and how we use donors' money. Number one, Ethiopia fortunately have been kind of, make donors operate in our terms in a way that we negotiate or they align whatever they do into our plan. So plan alignment is very critical. That's number one. Number two, we need to also move from what is called programmatic but gap filling into what is called a gap closing strategy. So this would moving forward, this is how we need to engage donors in the future. So because we've seen, the result of donor reliance entirely on certain essential healthcare services. So finally, I think and I believe, we talk a lot about resource mobilization, domestic resource using, but the most important thing is also efficiency. How we utilize our resources, also equally important, how we mobilize resources. So efficiency is also another area that we need to focus on. Ethiopia is actually working towards into that. So finally, before I close, I think this is critical. This is a critical moment whereby we need to speak the language of economics and health. We need to keep, being able to develop that set of skills to be able to negotiate with people in the finance sector so that we get our share in the health sector and including for women, children, and adolescents. With that, I close. Thank you so much.
Thank you very much, Solomon, and a lot to unpack there, both in terms of the identification of domestic priorities and also how the government has been building up towards sustaining financing by having cross-ministerial dialogues, but also where you landed us in terms of the need for alignment and bringing in the Lusaka, Sevilla commitments and how we do that. I particularly like where you ended in terms of thinking and working through the language of economics, financing, and health. And what better two persons to bring in at this point than Agnes Sukat and Calypso Chalkidu to share their reflections. And first to you, Agnes, you have been at the vanguard of global financing, economics, and health discussions for a very long time. And we would very much appreciate your views on how you look at the current financing landscape and models that you think can help us champion women, children, and adolescent health issues in these rather challenging times. Over to you, Agnes, and welcome.
Thank you very much. Thank you, Rajat, and thank you for organizing this this important conversation. And thanks to everybody who has joined. It's always a pleasure to be with the PMNCH community, who is such a driver for changing the circumstances in which women and children live. Yes, we are in a challenging environment, and for those of you who follow a bit our country, France, you know that we are going through times that are very complex politically, and this is just joining the curve, right? The complex politics is probably what all countries are facing now, and complex politics is also the situation geopolitically at global level. But try to just give a few short points there. First, and I will paraphrase what Mansour Ahmed has said recently, the Director General of the Center for Global Development, is probably development aid as we've known it is definitively a thing of the past. This should not be the primary object of our conversation. What are the object of our conversation when it comes to financing should be really how do we mobilize collective action, collective energy to mobilize financing, both funding and also developing financing institutions that serve women and children, that serve the poorest groups. And we know that the role of collective action and the role of collective financing is absolutely critical there. And that collective action is local, it's national, it is regional, and it is global. First and foremost, we know the amounts that are mobilized, that they are the two main sources of financing for health is first households. And this means that households need to be equipped with both information, but also equipped with the capacity to benefit from government programs, to be able to use the resources available the way that maximize their health. So it's really going back to basics, that health is produced at household level, which means that we're not talking only about health services, and you mentioned that in your introduction, and it was mentioned by Solomon, is that health is built multisectorally. And one first thing is really to make sure that the economic circumstances for everybody are developed in a way that maximizes this protection, particularly early age in pregnancy, because we know it defines the health of the entire life. We know all that from the literature on the life cycle, but it also determines intergenerational outcomes, so that if we want to tackle inequities, we need to invest there. And we really need to continue to invest in activities and programs that support households. And certainly one of the major lessons learned from the COVID pandemic, in what has been a success of the response, is social protection system and safety nets. And that's a way to support households. And more we need, and particularly as we see that only half of people in the world have access to health services. When we say about half, it's a very limited package of services, right? We're not even talking about something very expensive. When we think about the half that doesn't have access, we really need to think about how we develop those safety nets and those social protection mechanisms that will help build the right circumstances for families, for women and children. And then the second is really how do we mobilize collective money, and the importance of government financing in supporting programs and institutions that serve the poorest and serve the vulnerable. And there again, this is the second source of financing, right? This is domestic financing that is generated by mechanism at national level that produce tax revenue and develop national budgets. And then there is really an absolutely crucial role of this community to influence that through national dialogues, through advocacy, through budget watchdogs. The time is more than ever the time to work at shaping national budgets, particularly because we know that the issues of the health issues of women and children are linked to economic circumstances and poverty. We know that most of the poor live in middle-income countries, which have sizable public budgets. And the question is, how do we grow the pie of these public budgets, and how do we make the case in national institutions, including national parliaments, for budgets to go to maternal and child health? And linked to that, of course, in this advocacy, there is the technical advocacy, which we are very good at, typically in global health, to advocate for cost-effective packages and high-impact interventions. And it's an important role because if we look at the literature, we know that most of the key high-impact interventions for women's and children's health are among the most cost-effective interventions. And some of them are public goods and address market failures. So there is a need for government intervention. In that case, needs to be brought forward in parliament and in budget discussions. So that's really, I would say, the second thing. And last, although but not least, because we talk a lot about it, is how do we reshape global financing? And as I said, development aid is not the first source of financing for health, but it has still an important role for two reasons. The first one is that there are some global public goods, and the discussion that takes place around pandemic preparedness and some key health-related investments in climate resilience and biodiversity, fighting biodiversity loss, all the aspects that are linked to the environment. We know from recent work, including work in Pakistan, from Zulfikar Bhutta, is that there is a very important vulnerability of women and children when it comes to environmental challenges. So there is a need to rethink global health financing in the sense of leveraging domestic financing through some key mechanism at global level, and funding some essential R&D, some essential prevention actions through global and regional organizations. And there are a lot of discussions right now on how to reshape global financing. And the second argument for protecting some levels of flows of global financing is the fact that still some countries, yes, there are much less countries who are low income today than 20 years ago, but some of them still struggle to finance most essential services. And there, we really need to think on how we're going to transform the way we transfer solidarity financing flows to these countries, because those flows have declined, so they probably declined. They will be declining by about half or even more from pre-COVID, from a pre-COVID level, but mostly these flows to be rethought in the sense that they really need to take into account the substitution effect. A lot of the development aid money has actually substituted for domestic financing, and it should not. It should really be designed in a way that strengthens national institutions, that strengthens national systems, and really make sure that domestic money is allocated to step 0, step 1 of universal health coverage, which would be first spending on commons, on common goods for health, public health institutions, protecting the basics, and second on packages of most essential services, of which maternal and child health and adolescent health are absolutely priority. So that's sort of my thank you.
Thank you very much for that, Agnes. And I know there were some connection issues, but I think colleagues got the gist of what you emphasize, from collective action to technical advocacy to how we reshape global health financing and protecting the solidarity flows that you said. Calypso, coming to you next, and you, of course, have a formidable role, and congratulations also on your new role and appointment as the Director for Governance, Financing, and Economics at the World Health Organization. And we would very much welcome your reflections on how you are making sense of all the real world impact of the cuts that are happening, the guidance that you have been providing to countries on what can be done in this regard, but particularly from this webinar's perspective, what can be done for the vulnerable women, children, and adolescents in this context. Over to you, Calypso, and welcome.
Thank you. Thanks, Rajat, and thank you all. I've got just 3 or 4 slides to go through some of the green numbers that I think you've already mentioned. First of all, why are we here in this sort of macroeconomic crisis that's affecting countries' ability to spend on social programming? And during COVID, governments were encouraged effectively to borrow to spend on addressing the pandemic. According to the OECD, this spending to some extent crowded out spending on other things. And you can see during that period of 19 to 22, we had more money for pandemic preparedness and response and less for primary healthcare, basic nutrition, family planning, and reproductive health. Now, of course, this is subject to the way one tags, labels these different types of spending. Nevertheless, I think we wouldn't be honest with ourselves if we were to argue that all the extra money we saw was actually truly additional. And this speaks to the point that Agnes mentioned earlier. There's always crowd out effects, and need to be very intentional and very careful about at the global level what these trends of financing, the advocacy efforts of financing specific things may be causing on the ground. And then interest rates went up. Debt interest rate, servicing the debt became extremely expensive, especially for low middle income countries. And this is now what is crowding out even more domestic health spending. And so in 2023, 3.3 billion people living in countries spend more on debt interest payments than on education or health. The more recent data from UNCTAD is similar. 2024, 3.4 billion people. So things are not getting any better. And then the bottom, a good report from by the FDL, and all the links we can make available for you, for those of you who are interested. Interest payments in 2020 were about 60 billion for low and low middle income countries, and in 2023 had climbed up to 108 billion. This is an 80% increase, but the debt stocks, the actual amount of debt, actually had only increased by 13% over the same period. So what has been happening is that the debt has become really, really expensive. It's not that these countries actually borrowed excessively, if you like. I don't know, can I move the slides, or maybe you could, the next one, please.
So I think you can.
I can?
Okay.
Yeah. Okay, I can, indeed. But this comes, these shocks, the pandemic shock, the shock that has resulted from the interest rate hikes, all these come on top of a chronic underinvestment in health by lower and lower middle income countries. And this is again what Agnes alluded to. We've got, according to our data, 35 low middle income countries, home to over 2.5 billion people. Well, government health spending, or the share of health in government budgets, has actually declined during the pandemic response and recovery period, and is continuing to decline. 42 countries spend less than $30 per person per year on health. 20 lower middle income countries, their health system is actually predominantly financed by out-of-pocket payments. So we're looking at a situation where a large number of countries, out-of-pocket payments, the least efficient and the most inequitable way of financing a health system, is actually the major driver of financing, followed by aid. And there you've got, of course, aid volatility that comes with aid dependency, and we're seeing the results of that in the current climate. What is also very worrying is that these are not funding flows that target specific diseases or interventions, but actually funding for primary healthcare is very much dependent on external flows. So what some of the analysis we've done suggests significant decline in ODA in this year compared to 2023. More recent data from our OECD colleagues suggest something similar in bilateral flows. So we're looking at levels by the end of the calendar year that are way below the average, and indeed the lowest level of ODA over the past decade. And this, of course, will have an effect on programming. Low-income countries spending on women, children, and adolescents relies more on aid than on domestic public spending. More than 30% of spending comes from external aid, 20% financed through domestic spending, and half of total spending, roughly half of it, comes from private sources, mostly out-of-pocket payments. As I said, the most inequitable and most inefficient way of financing essential services. Of course, at the same time, countries are, the narrative at least is that countries are stepping up. We heard from Ethiopia, stepping up to fill the gap or find ways of addressing also the programming gaps. It's not just the financing gap, it's also a visibility gap, it's a capabilities gap. And we're not arguing here for dollar-to-dollar substitution, but nevertheless, it is important to look at where the funding and the efficiency of funding committed to those priorities. So to close the broader picture, in order to navigate this steep health financing cliff, fiscal capabilities, engaging finance, engaging parliament, and we heard from Ethiopia, hopefully we hear more examples of this kind of dialogue where ministries of finance are actually prioritizing health and investing additional resources in health. Efficiency and priority setting, it's not just about more money, it's about spending the money better, improving public financial management systems, investing in cost-effective interventions, and really running the government, creating the plan and getting donors to support this plan. Political advocacy domestically and globally for health, and then a different approach to aid. And as Anya said, aid as we've known it for the last 2 decades or so is dead. The model is no longer viable, and that's a problem in terms of the very steep, very abrupt cuts. But at the same time, I think it's an opportunity to reflect on how to change this situation as we move forward. And there, I think the way foreign donors behave and finance is really important. Yes, it may be less money, but that money needs to go towards government priorities, towards supporting institutions, not replacing core government functions, but supporting them, avoiding taking over recurrent costs, aligning to country priorities, as I said before. So with that, I will leave you. Thank you very much for joining, and thanks, Rajat, for having me. Thank you.
Thank you. Thank you, Calypso. And before we transit to the next panel, which is on evidence, I know, Calypso, you have to leave, but there are a couple of questions that have come up in chat, which I wonder if I could quickly revert back to Agnes, you and Solomon. One is, how do we leverage the untapped potential of private sector investment, which, as Stefan points out, ranges between 25 to 50% in certain countries that we are talking about across not just sub-Saharan Africa, but in other country contexts as well. The second is, I think, Solomon, directed to you in particular, is the question about working across line ministries. And you raised that important point, reaching out to Ministry of Finance. What were some of the learning from Ethiopia? And then finally is the question about how do we sustain the commitments that have been made in these rather challenging times, whereas both Agnes and Calypso talked about there is a crowding out, which is starting to happen. Couple of minutes, let me go back in the same order that we started. If I could please request you to be brief, that will be great. And then requesting Mary and Gavin to be ready for the next panel in the meantime. Solomon, first to you, please.
Thank you so much, Rajat. I think there has to be a smooth transition from ODA to domestic financing. For example, Ethiopia, like the moment that we know that there is a huge budget cut from the ODA, what we're trying to do was that looking for other donor sources. No, this time, you need to multiply your donor sources. Unfortunately, there are philanthropists who are willing to step in to support us. And somebody was asking me, where do you get the money for the RNMSH 2025? I think we already have secured a huge amount of money for RNMSH Compact, and most of the money comes from philanthropists. So so we know that ODA is not sustainable. We know that moving forward, the only way that we can finance our healthcare, including women, children, adolescents, is through domestic resource mobilization. That is known, but that comes at a cost of loss of life. So we don't have to sit and watch people suffer as a result of serious budget cuts. So we've been looking for multiple donor sources, and we have it now. So we're transitioning it smoothly. About for somebody, it was Alex who asked this question. So we already secured the money. We have a compact RNMSH contact with a huge amount of money. Just want to give you my word on that. The second point is, previously, the interaction across ministries was not that strong. We never had that conversation, sitting with staff from the Ministry of Finance and sit with them and kind of talk to them and negotiate for resources. That has never been strong, even though there are a bit of efforts here and there. But recently, this one of the positive aspects of this budget cut is that now the finance people already know that there is a huge budget cut. Health is not anymore funded hugely from donors. So now they also see the case. So this creates an opportunity for us to sit with them and negotiate and show them the impact of not financing health, especially the impact it's going to have on women, children, and adolescents. And then people were willing to actually be able to, listen to you and put more money, more resources into healthcare and RNMSH services. So the lesson is now, that negotiation, that, choosing your words when you talk to the finance people, showing them how important the case is. Making a case is very, very critical. So we're not going to stop here. We continue on this conversation with the Minister of Finance people. What we have right now is not enough. We need to continuously engage them and to have more resources, convince the parliamentarian, convince the policymakers in the future as well. So that's briefly what I have, Raja. Thank you so much.
Thank you. Thank you for that, Solomon. And thank you also for Stefan for popping in that extra explanation, is that emphasizing on the private out-of-pocket expenditure, what he was referring to, but we also have a question about the private sector, which is heavily involved in the delivery of healthcare in many countries. Agnes, first to you, and then Calypso on any reflections on those or other issues.
Yeah, thank you. Maybe 2 points on how do you raise domestic financing. I think the first thing we have to say is many health budgets in low-income countries, in low-middle-income countries, are actually not spent. They are voted, they are budgeted, and they're not spent. And one of the reasons they are not spent is that substitution effect. Is like money is was brought by development aid for mostly medicine and immediate low-hanging fruits, but was not brought to the health systems. And one of the blind spot in health investments through global health monies over the past 2 decades has been human resources. Right? Something like a country like Côte d'Ivoire has been training 120 doctors per year, which is a ridiculous number. So there's been no investment in really actually producing the kind of human resources who will be the ones who are going to implement and actually make these programs happen. There has been also little investment in hospital infrastructure, there's been little investment in institutions that manage health services. So this is one of the shifts that needs to be made in global solidarity that we need, and Ethiopia is an example of this shift, right? They have a national health plan that they describe, they have national strategies, and then you can mobilize external financing. Once you actually have your priorities straight and you invest in your system, you invest in the pipes that are going to implement. And the second thing in domestic financing is we know that there are, potential fiscal instruments that could be win-win. That's the discussion about health taxes, whether it is tobacco, alcohol, sugar. And the experience is actually really promising, right? Because this is also a way to have a conversation about the future health challenges, the NCDs, but also the way about the type of taxation that a society chooses. And last but not least, on domestic financing, which I mentioned, is how you actually advocate your political system. You actually work and that all these groups, these women's groups, this technical advocates, but also the NGOs, the CSOs, how they shift their attention from advocacy towards donors towards advocacy towards their own parliament and their own government. And on trade financing, I'll just something very short. There is certainly, now we see it very much a need for governments to provide enabling environments for private financing to be invested in the investment side of health, investing potentially in infrastructure, investing again in human resource training. But we should always be cognizant that that private sector financing is not likely to go into recurrent cost, right? Maybe you need financing to build a hospital. But you need to think at the same time how government is actually going to subsidize that hospital. Because this is not going to just happen through private financing. Thanks.
Thanks, Agnes. Calypso?
I think everything has been said. I agree with Agnes. I put in the chat the Jubilee report commissioned by the Vatican and led by Joseph Stiglitz and other economists. I think when we talk about private financing, as Agnes said, it can't be the driver. Private, I don't mean private out of pocket, which definitely we need to make sure it's reduced. But private investment is very important, but it can't be the driver, the biggest driver of financing a health system. That has to be budgets, and it's going to be gradual, but it's important that that's the end objective. And when we look at private financing coming in, it has to be driven towards the best buys, the priorities of the government, and investments that will return in the medium to long term, both social and economic returns, because otherwise the money is effectively wasted and you end up with the debt. So I think that the report is actually quite enlightening in terms of also the situation right now, and offers some solutions for the future. Thank you very much, Rajat, and everybody.
Thank you. Thank you, Agnes. Thank you, Calypso, and thank you, Solomon, as well. And shifting gears very quickly. So, we had policy perspectives. Now we are diving deep into the evidence. And great honor and pleasure to have with us Gavin Yame and Mary Kinney, both of whom have shepherded two remarkable series in the past months. And they would be sharing with us some brief reflections from the evidence that has come out. I'll first go to Dr. Mary Kinney, who has been the managing editor of a recent collection focusing on global financing facilities, investments, and processes and alignment with national priorities. Mary is based at University of Western Cape and worked alongside people from Nest 360 Alliance and the Gates Foundation on this wonderful collection that she will give us an overview of. Mary, over to you.
Thanks, Rajat, and greetings, everyone. I'm presenting actually on behalf of a very wide team, the Countdown GFF Policy Collaboration. Our research examined the national priorities, processes, and investments related to the Global Financing Facility, or GFF. So the GFF was launched in 2015 as a new way to fund the health and rights of women, children, and adolescents. Hosted at the World Bank, it aims to unite partners around one national plan, align investments, and mobilize more resources.
Mary, sorry to interrupt, but could you shift the slides into slide mode because they're not very legible at the moment.
Oh, sorry.
Wonderful. Thank you.
Is
Sorry
that
to
better?
interrupt.
Do you see them well now?
Yes, we do. Thank you.
Okay. Great.
Sorry, it went back.
Like that.
Yes, thank you.
Okay, sorry about the technical. So you can see here a figure from one of the original GFF documents that shows that the GFF Multi-Donor Trust Fund aims to be a catalytic, mobilizing other resources from government, World Bank lending mechanisms, other donors, and the private sector. As the first global health initiative specific to this population, the Countdown to 2030's Health Policy and Systems Group wanted to learn more. A collaboration was started in 2021, building from our previous work related to the GFF. And the group was African-led, mostly African-based, multidisciplinary group of academics, policymakers, and civil society actors. What did we do? We reviewed GFF country documents from 28 countries, including 24 investment cases and 30 World Bank project appraisal documents. And these documents include the GFF grant. And we systematically assessed the content and themes in the documents and the processes by which they were developed in countries. And this has resulted in 9 academic papers published in the Global Health Action Journal, 1 overview paper, 1 papers that focused on the thematic content analyses, 1 on adolescents, 1 on maternal newborn health, 1 on quality maternal newborn health, and 1 on community. And then 4 country case studies, Burkina Faso, Mozambique, Tanzania, and Uganda. And it's accompanied by an editorial and 3 commentaries, including 1 from GFF leadership, 1 from PMNCH, and 1 from health policy and systems researchers in Africa. And so what did we find? This is the meat. First, the GFF elevated the health and rights of women, children, and adolescents in policies and programs. It brought new attention and resources to national plans, ensuring alignment, visibility of RMNHC policies. So for example, in Burkina Faso and Mozambique, there have been fragmented RMNHC policies, and the investment case brought them into 1 document. Second, our mapping of the investments in the 30 GFF-linked World Bank project documents found that $14.5 billion was mobilized in the first 7 years of the GFF. The GFF actually comprises a small amount of this amount at 4%. Most of the funding came from governments and low-interest World Bank loans. However, many country stakeholders did not understand the GFF approach or that their loans are tied to, their grants are tied to World Bank loans. Third, country ownership was uneven. The GFF emphasized country-led processes and plans informed by the evidence, but we also found that power and politics really played a big role in shaping the documents. Some actors were initially not engaged, like civil society, youth, and private sector, but this may be improving with time, as demonstrated in the study from Tanzania, which compared the first and second phases. We also found that the investment cases were these broad, comprehensive documents with many priorities, often developed through inclusive processes, whereas the GFF-linked World Bank project documents addressed fewer priorities, sometimes didn't clearly align with the investment cases, and were developed with a few actors, notably World Bank, government, and GFF. And finally, GFF demonstrated a willingness to learn and adapt over time. While the GFF-linked projects in the early years lacked key measures of impact, quality, and equity, GFF did invest in stronger data platforms, monitoring and evaluation. And we found that the GFF, engaging with them throughout the study process, was constantly changing and responding to gaps identified and adjusting as needed. And so what? Given the current financing climate, the GFF's future trajectory has even more influence and importance for shaping health outcomes for women, children, and adolescents, as well as sustainable health financing. So now it's the time to accelerate efforts to work with and strengthen country capacity to lead through inclusive platforms and address power imbalances, secure fair long-term financing, and ensure independent accountability. At this QR code or link, you'll learn more about the series, which is now available online. Stay tuned for more details of a webinar where we'll dive deeper with more members of the collaboration around the series. Thank you.
Thank you. Thank you, Mary, for laying that out and the enormous effort that you and partners have undertaken for doing this documentation. And as you said, GFF has provided us with a phenomenal opportunity, and it's galvanized efforts at country level, at global policy level, and as we move into the future, how can we continue to build on those successes, but also learn the lessons from the past. And we will have an opportunity to learn to hear more from GFF itself in a moment. But before that, Gavin, if I could come over to you, you spearheaded another remarkable effort, that is the Lancet Commission on Investing in Health. We do have a couple of your commissioners on the line who will be taking floor as well as we move through the conversation. But Gavin, would very much welcome your reflections on how Commission's findings can help us guide the prioritization of budgeting and progressive realization of UHC, and what are some of the implications that you point out in the series for women, children, and adolescent health. And thank you really for joining us at this early hour in North Carolina.
Thanks so much, Raja. Can I just check, can you see me, hear me, and do you see my slides?
Everything, yes.
Brilliant. Thanks so much for PMCH for the invitation. It's really a great privilege to be on such an esteemed panel, and also to be amongst so many tremendous colleagues all around the world. I've been watching the chat with great interest. So good morning, good afternoon. I'm still being caffeinated here in North Carolina. I am going to present just 3 key messages from the latest report of the Lancet Commission on Investing in Health, the CIH. It was the 3rd report, or CIH 3.0. We had 50 commissioners, and as Rajat said, a couple of them are with us on the panel, Flavia and Agnes. Commissioners were from all over the world, including Leah Gebremedin, who was the former Minister of Health of Ethiopia. The report is called Global Health 2050, the path to halving premature death by mid-century. So I'm actually going to be somewhat optimistic in my remarks, and I'm going to focus my 5 minutes on the implications of this report for women's, children's, and adolescents' health. So the first message is that nations that choose to do so can achieve what we call 50 by 50. And what we say in our report is that dramatic improvements in human welfare are achievable by mid-century with focused health investments. And by 2050, countries that choose to do so could reduce by 50% the probability of premature death in their populations. What we mean by premature death is death before 70. And that is from a baseline of 2019. So 50 by 50, halving the probability of premature death from 2019 to 2050. So that is in 31 years or less. And there are 2 reasons why we are optimistic that 50 by 50 is feasible. The first is historical experience. Since 1970, there are 37 countries that halved their probability of premature death in 31 years or less, including 7 of the world's 30 most populous nations: Bangladesh, China, Iran, Italy, Japan, South Korea, and Vietnam. There's a second reason for optimism, and that is continuing scientific advance, which I think is absolutely crucial for the discussions today. Dean Jameson and colleagues showed that about 80% of the decline in under 5 mortality in low and middle income countries from 1970 to 2000 can be attributed to the dissemination of new health technologies. And based on what is in the product development pipeline today, provided we scale up financing for R&D, and that's crucial, our research found that we are likely to have around 450 new medicines, vaccines, diagnostics for infectious diseases and maternal health conditions by 2050. A second message is that sharp reductions in mortality and morbidity can be achieved early on the path to full UHC. We show in our report that 50 by 50 can be achieved through prioritized investment in 15 key conditions. And as Rajat mentioned at the beginning of today's conversation, 8 of those are infectious and maternal, shown here: neonatal, respiratory tract infections, diarrheal diseases, HIV, TB, malaria, the childhood cluster diseases, and maternal conditions. 7 are non-communicable diseases and injuries. And these 15 conditions account for a very large fraction of the life expectancy gaps between the highest performing regions and other regions. So for example, if you look at 2019, life expectancy was 60 years in sub-Saharan Africa, it was 82 years in Western Europe and Canada, and about 3/4 of that gap was from these 15 priority conditions. And our final message relevant for our conversations today is that for many countries, reaching 50 by 50 is going to need a focus on women's, children's, and adolescents' health. That definition of premature mortality that I gave at the beginning, that covers the whole period from birth to 70 years, right? The whole lifespan. But in fact, we find that in over 60 low and middle income countries, premature mortality is actually concentrated in children, and that the deadliest age interval before 70 is from birth to 5 years. And so the next phase of our work, we are going to be looking at, well, what would it take for countries to reduce under 5 mortality by half by 2050, or 50 by 50 for U5M? And we're actually not just focusing on that 5-year period alone. We're actually going to be looking at mortality, premature mortality, disaggregated into 4 periods: neonatal, under 5, 5 to 15, and maternal. And there's clearly a lot of work being done by others, PMNCH, UNICEF, WHO, academics, and we'll want to synergize our efforts. And here are the 6 key research questions that we will be addressing. What progress have countries made in reducing mortality in these age periods? What are the main causes? What are the main policies that are likely to reduce child and maternal mortality, both within the health sector and related to socioeconomic determinants? We have been very interested in the role of a public subsidy mechanism to help make children's and maternal health commodities and other interventions more accessible and affordable. We've been calling this the Arrow mechanism after the late Ken Arrow, who was the intellectual architect of a subsidy mechanism for malaria medicines that you may remember, called the AMFM, the Affordable Medicines Facility Malaria. We have already started working with many governments, including in Ghana and Nigeria, looking at the role of this kind of subsidy mechanism. A critical question that I know PMNCH is also working on: which interventions should be prioritized in an environment of constrained health ODA? What is the role of new technologies? And our study will also look at one non-fatal outcome, the role of nutrition on child development. This is my last slide. I just wanted to say that the series of country chapters of the Lancet Commission on Investing in Health are now underway. They have launched in China, Nepal, Nigeria, the the United States, and they are taking forward the recommendations of our Global Health 2050 report at national, or actually in China, even at sub-national level. This is a photo from the recent launch of the Nepal Commission on Investing Health. There were over 80 policymakers, researchers, healthcare professionals, including Nepal's Minister for Health and Population, Pradip Paudel. So just to conclude, Global Health 2050 shows that a practical pathway to 50 by 50 is within reach. And by focusing investment on prioritized conditions, 15 of them, 8 of which are women's, children's, and adolescent health conditions, and crucially, by financing scale-up of R&D financing, we think that the global health landscape can be transformed, despite the challenges we've been discussing today, can be transformed within our lifetimes. Thanks so much for the opportunity.
Thank you for that, Gavin, and to you, Mary, as well. And before I do transit into the final panel, which is on practice, I do have a couple of very quick questions I want to come back to you and Mary for. The first one, Mary, is to you. We heard a lot, and this come up in the chat as well, the need for alignment of investments and any learnings from the series that you have edited with colleagues that can help us showcase how can partners and policymakers work to ensure investments are indeed aligned to country needs. And of course, everybody much reflecting on Lusaka and more recently on the Sevilla commitments as well. So any thoughts there? And Gavin, to you, there are two questions. One is with regards to how do we address the investments priorities model that you have outlined in the Lancet Commission in a world combating multiple intersecting crises? And how does the context help us or deviate us from the investment model that you and other commissioners have outlined? And then the second question, which I think you were starting to answer, is from colleagues like Ann Stars and others in terms of investment into specific services and commodities, such as those related to sexual reproductive health, family planning, abortion, and does the Commission go into that, and also on adolescent issues? Mary, may I come to you first and then move to Gavin for his response? Over to you, Mary.
Thanks, Rajat, and thanks for the question. You know, I think when we look at country priorities, it's whose priorities within the country, and are the right people around the table to determine the priorities. And what we found with the investment cases is that there were these long list of priorities, and they were inclusive processes, as I mentioned. But it was hard for us to understand and track just by looking at the GFF linked World Bank documents, just by looking at one part of that investment case to see, well, are all of those priorities actually being resourced? You know, are they aligning? And so we were only looking at a fraction of what that was supposed to be. And we did see that some of the investment cases and the pads were they were speaking to each other, they were linked, and some there was disconnect, and we struggled to see where the connection was. And in our conversations with GFF, they were also saying, well, that was what the government said they needed as a priority for alignment, you know, and for investing in that part. And I think one of the challenges we have is actually that mapping of resources. So since we started doing this work, GFF has been trying to work to map resources. If you go on their data portal, you can see countries, you know, kind of it's a pie chart showing the different donor resources, which I'm sure is drastically going to change this year. But really, whose priority, who's actually funding what part of the investment case, that mapping isn't publicly available, and even their source of how they're getting that information isn't publicly available for academics to understand, you know. So I think that there's a lot of need for more transparency around what's, you know, alignment and who's contributing to what. Are these priorities actually being funded?
Thank you for that, Mary, and also something that Agnes said early on in terms of when we do think about strengthening our budgetary financial advocacy efforts, how do you address the complexity and often opaqueness of processes at the national level, make some of these issues more hard to track? Gavin, over to you, and then I'm moving into our final panel.
Yes, sure. Thank you, Roger. I'll be very brief. On my office door at Duke, I have a quote from Gandhi, which is, it is health that is real wealth and not pieces of gold and silver. And I think that that is part of my answer to your first question, right? That, health is the mother of all development sectors. And we do show that in our report. I'll put the link to our report and to translations of the report and to short briefings and videos where we look at the returns. We look at the extraordinary and enormous returns to investing in health, health returns, economic returns, impacts on other sectors. And I do think there's value in demonstrating those returns and in making the case and the advocacy case to the Ministry of Finance. And then on your second point, yes, we do lay out the specific interventions and the specific services where the evidence has shown that the impact is enormous and the cost effectiveness is high. We work very closely with DCP3 on marshalling that evidence. And I would say that that is another really valuable resource for discussions today, and DCP4 is underway. And I'm really very excited to see DCP4 as well. So I think the evidence on the specific interventions and services is also robust. Thanks, Roger.
Thank you for laying that out, Gavin. And that nicely brings us to the final session, which would be looking at solutions for financing women, children's, and adolescent health and well-being. And great pleasure and honor to have a formidable trio of speakers: Luke Laviolot, Joel Kinderbrego, and Dr. Flavia Bustreo. Luke, pleasure to have you with us. You have the formidable task of heading the Global Financing Facility Secretariat, one of the most important initiatives in our sector addressing the financing needs for women, children, and adolescent health. As you know, the goal for our collective efforts is to increase and better financing for women, children, and adolescent health and well-being. And I would really like to go to you first to understand how can we support this issue and equity enhancing financing investments for women, children, and adolescent health, and what are some of the things that you are thinking of as you look into the future? Over to you.
Thanks, Rajat. And one of the privileges I have of being in this job is I sit on the board of PMNCH. I'm very proud of that. And thank you for bringing us together today. And also to the authors of the GHA series and of the Lancet for the presentations. They're really useful. And for us, I mean, the whole process of engagement, Mary, with the team has been, as you mentioned, really productive, I would say, and very, very useful. Maybe just, and I don't need to say that today's discussion comes at a really critical time on the health financing landscape. A lot has been said on that, so I won't cover that. But it is very much part of the backdrop to where we're at the GFF and what we're thinking. We're currently, as many of you know, because you've been part of the consultations, in the quite an advanced stage of developing the next strategy for 26 to 30, and so I'd like to share some of the thinking there. Within days, there will be a first draft of the full paper publicly available on our website for comments. We look forward to receiving additional comments. But maybe just to take a few steps back and add a little bit more detail on what the model is for those online who may not know all the details. So it is a country-led partnership, and I think the point that was made earlier, so importance of the partnership aspect, but also the country-led aspect. And the point of what country means and who in the country and the political economy of that is well taken. We've had a lot of learning there. It's government, but also way beyond government. And civil society, for example, is an area where or a group of quite a diverse group within countries that we've engaged with a lot more. And very concretely, we've insisted and created the space, frankly, in several countries to have not only a civil society seat at the platform, whatever countries choose as a platform, but also a youth representative, because we learned over the years that the two are not always the same, and that the space for youth was not big enough. So lots of learning there. It is first and foremost a financing mechanism. We all know that 10 years ago when it was created, we were looking at the SDGs. We knew we needed more, but also better utilized funding. And it's already been mentioned that it's very much a catalytic type of tool. So the grant funding, and we've been successful at mobilizing $2.6 billion of donor grant funding from 17 donors is important, but it's actually small relative to the total needs. And our task, our formidable task, as you say, Rajat, is to try to minimize the outlay of grant to maximize the crowding in of domestic resources, starting with the World Bank financing, which is a form of domestic resources because the World Bank allocates through a formula a pot of money to every country, and they can choose to invest that in any sector they want. Ministers of finance decide that. We bring an incentive through the grant to actually allocate those funds to women, children, and adolescent health priorities through the health sector, but also through other sectors. So we had Agnes mentioning social protection earlier. We have had experience working through social protection to sharpen the equity focus, and it's something that we would want to do more of in the future. So we've had a 1-to-7 match to IDA, and actually in recent experience, even higher match. We've crowded in domestic resources, but also a sharper focus on aligning the external financing. In the last few years, we've developed what we call the joint financing framework, which enables donors to come and co-finance the World Bank project, which means because all of our funding, the World Bank funding, is always on budget and always works through government systems. And we know that's not been the case with much of the external assistance, and so or ODA. And so that alignment agenda is not only for like financing the same priorities, but also doing it through the budget and government systems. 36 countries are currently part of the partnership. We're very proud of that. But actually, as we took a few steps back in developing the current strategy, we looked at the global burden, and you do see gaps actually in terms of very high burden countries that are still not covered. Some, high burden countries that could graduate, and so we're shifting that, and I'll speak a bit more about that in a minute. So step one is that we incentivize countries to allocate the IDA. So that's really the sharp focus of our work. We also, step two is then really, as Mary mentioned, is focusing on the design of that IDA, which is always part of a larger government program. And sometimes it is a subset of the investment case, and sometimes it's more of the broad, full coverage of what's in the investment case. And the important third step is also the various forms of technical assistance that we provide along with others, but increasingly looking at how we can pool that to support the implementation, the learning along the way, a lot of focus on data. And that focus on data, as has been mentioned, has grown in the last 5 years, I would say, the second half of the first 10 years. So it's really not just about more funding, because that's important, but also about how the funding is utilized. We really welcome, as I said, the review that's been done. It's been really useful for our learning and has informed key elements of the next strategy. Maybe a few points to respond or to add. I mean, of course, there's some limitations to a document review approach, and we've discussed that extensively with the bank, I think, with the colleagues of the Mary and other colleagues. But it also speaks to our need to document more and be, sort of create more transparency by through the documentation. So we've definitely learned that. We're also very mindful, because we've heard it through a number of means, on the need to achieve, I would say, a better balance between what we were initially in the early years focusing on country leadership, and that we didn't feel a need to be as visible and the processes to be as visible, and the need for visibility, not just for the cause, but also for our ability to all know how the model is working, and to be able to demonstrate clearly the value add in a model that is contributory, not it's about contributing to a government and to a wider country effort. And then finally, on the issues that were raised, the ownership is variable, and it's actually something that we all are aware of, right? Country leadership in this space is variable, and it affects in many ways how we can engage through this model. And we've had lots of internal churning on this, and some of it is, you engage to build the leadership commitment, et cetera, through advocacy, et cetera. But we do believe we should still engage. So as we look forward, I won't go through the prospects for financing. We know that the domestic resource fiscal space is not large. the current level of funding, it's all good to say we need to improve efficiency, and we are focusing on that. But I want to emphasize how constrained the financing is. So for countries that may need around $60 per capita or per person to deliver a core package of services, our estimates at the World Bank right now is that the average is about 17. So you can pull out more quality and services out of that 17, but it's extremely low. So we do need to crowd in more. I do think that there's been, and it's been mentioned, quite a shift with the rapid reduction of ODA in the incentives for governments to actually put domestic resources on the table. We plan to support that in doing that. So there's three areas in the new strategy that we are looking at, three strategic sort of pillars, if you want. One focuses on, one is a sharpening of what we've been doing, so really building on what I just explained. And it's about crowding in funding, and in three ways, I would say. First, that focus on IDA. It's IDA 21 was reasonably successful, quite successful, I would say, in the current context. It is one of the largest sources of external, but also, as I said, can be considered a domestic form of resources available out there, but there's no guarantee that it'll go to health. There's lots of competing sectors, big pushes for energy, agriculture, etc. So our role in using the grants to incentivize a shift to health continues to be important. As I said, and most of what we've done so far, it's at the core of the model, and we maintain that. We think it's the secret sauce, if you want, of the GFF. But we do think that we can do more with the most relevant non-health sectors, for example, to improve equity, working with social protection, governance, to strengthen systems, etc. So that's one. Second, domestic resource mobilization. And there, it is about growing the pie, but we think there's also a way for us to use the strong investment we've put in data to support, for example, ministries of health to make a better case that health is an investment, but also health is producing results. They can provide more data on results, etc. We're seeing the national routine health systems improving rapidly, and we're very involved in supporting countries on data use. It's one of the ways. It's not the only way in which domestic resources will be released, but also greater engagement with parliamentarians, which was also mentioned. And then the third, focus on alignment. So really using that joint financing framework tool a lot more, so that whoever external donors are available, that we could provide that service for alignment. So that's pillar one. The second one has a lot of what's new in this strategy. It's accelerating efforts. First, by segmenting the way we work. So when we looked at the burden, we had the highest burden countries, very high burden, and high burden. And so there's a core package that we currently provide, that we would continue to provide. But in the 16 highest burden countries, we would really ramp up. So working in more sectors, a larger grant envelope, and a wider range of technical assistance, and more of a presence in the country. And I can unpack that further later. A greater focus on scaling up innovation. We know that there's a huge buildup of very exciting, very promising innovations that are well proven, but not yet scaled up. And our value add in that space is in de-risking the use of domestic resources to scale up innovations. And the de-risking happens within the project, the IDA project initially, through the grant funding that we give. I can tell you, when we negotiate these, often the ministries of finance at the end remove the innovations if they're using the loan, because they're not as comfortable with it. So what we do is we say, well, if you still want to do this, it is a way in which you could use the grant, and it's been working. We've got a really good experience in Tanzania, for example. And then a much sharper focus on incentivizing domestic financing for commodities for RMCHN and family planning. And then finally, a continued but deeper focus on resiliency and country leadership. We have a ministerial network. There's a network of female leaders in health. The role of civil society here is really important. But also, and maybe I should have started there, immediate support for rapid prioritization to help countries respond to the shock. We're actually in the midst of doing that now, with some 25 countries being supported. But also, as we do that, also in the medium term, building that capacity, working with others, because others are also working on this, of planning units, etc., to have that capacity to pivot more rapidly to the data they need, etc. So Rajat, sorry, I was a bit long, but I'll stop there and see what questions come up. Thanks.
No worries at all for that, Luke, but very, very helpful for us to have this, broken down into those different segments as you did, because often these details are not very well understood. But I do appreciate the overview that you have provided in terms of not just, the successes we have had through the GFF model, but also the challenges we face and how GFF is reprioritizing as it launches into the new strategic framework, but also addresses the complexity of financing in a world in which we are seeing a very rapid decline in resources being available. Thank you for joining us. I know we are running out of time, but we do have two very important speakers with us. Next up is Joel. You are a key author for the series that we have just talked about. But you are also, Joel, we didn't have time for long introductions. You are both representing Ministry of Health for Burkina Faso, but also University of Joseph Ki Zirbora at Ouagadougou. Thank you really for joining us, Joseph. So if we could turn to you and ask for your reflections on how we can best ensure we are indeed supporting country-led health systems and reforms. Over to you, Joel, and welcome.
Okay, thank you very much. And as you said, I will share important insight from the Global Health Action Series that Mary presented. And we can retain three critical lessons. The first one is that national ownership matters a lot. And the GFF works better when countries are in the driver's side, when priorities through inclusion and evidence-based processes are implemented. The second lesson is that alignment with national strategies is important. So investment must not be parallel, but must reinforce our national health development plan and midterm expenditure framework. And lastly, we can say that the financing must be sustainable. And while catalytic funding is important, the long-term impact comes from mobilizing and managing domestic resources more effectively. And to apply this in the context of Burkina Faso, so we can say that the country already has taken important steps to strengthen the financing of health for women, children, and adolescents. The first one is the prioritization. So through the National Health Development Plan and the investment case that the GFF supported. So we have clearly identified high impact intervention, such as maternal and newborn care, nutrition, and immunization. And these priorities are guiding both government and partner investment. So, but we want to go further in Burkina Faso, and we have undertaken to digitize the operational action plan of all departments within the Ministry of Health, and which provide us real-time information and plan activities very relevant and capacity to have a real impact on the health of the population and the level of achievement, including in terms of budget execution. So the second reform we did in Burkina Faso is setting up a dynamic resource mapping. So it's one key innovation that help us to know in real time who is funding what and where. And this tool not only promote alignment among partners, but also help us to increase accountability and transparency, to identify gaps, to avoid duplication, and also predict future funding trends so that we can better plan the sustainability of intervention. And also these tools help us to anticipate future funding needs to sustain women, child, and adolescent health. Now I'll talk a bit about the domestic resource mobilization. Currently, in the context of Burkina Faso, it's difficult to increase tax revenue for health, including mobilizing resources from the for-profit private sector, given the security situation the country is facing, which absorbs a lot of resources. So we decided to focus more heavily on efficiency gains and the intelligent use of resources, including better coordination of intervention and stakeholder. And we believe that the two important reforms I talked about, namely the digitization of the operational action plan and also the dynamic resource mapping system, can help achieve this and are among the best way to mobilize more domestic resources for health, including for maternal, newborn child, and adolescent health. So to conclude, I want to underscore that financing women, child, and adolescent health is not just a matter of more money, but also better money, better alignment, and stronger country ownership. So domestic and political commitment combined with smart catalytic financing can make a real difference. So it's what I want to say and share about Burkina Faso. So thank you very much.
Thank you. Thank you for joining us, Joel, and for that very clear presentation on how we need to ensure alignment with country priorities and strengthening health systems. And please do read the paper that Joel mentioned. Flavia, last but certainly not the least, over to you for your reflections on what do we need to do to ensure that women, children, and adolescent health investments are continued to be considered a critical priority. Over to you, Flavia.
Thank you. Thank you so much, Rajat. And being the last, I have the benefit that I cannot go over time. Before I address what needs to be done, I wanted to spotlight one element that has not come in this conversation yet. Historically, when we look at the financing for women, children, and adolescent health services, one typical feature has been the fragmentation of that financing, because it came through a lot of external programs addressing immunization, addressing HIV/AIDS, addressing nutrition, addressing family planning, reproductive health, addressing maternal health services. So in my personal view, the fact that the external financing is reduced could be a good moment for tackling one of the critical elements that do not allow the effectiveness and the efficiency of those investments, which is the fragmentation. So this one point, I think we have to keep it into mind, because we know, and the PMNCH has been at the center of it, that investment has to be across the life course. There is no point in addressing saving life of a newborn from asphyxia and then not taking that very same child when it's at the school age to be very, very nourished, or maybe to suffer from anemia, and when she becomes a teenager, to not have a teenager that is educated about her own sexuality and end up pregnant. So addressing this across the life course and addressing the fragmentation of the financing, in my view, is one of the critical elements that we are ought to tackle in this particular phase that we are. And to some extent, the instruments that now are coming to the fore, even with more relevance, like the Global Financing Facility, which I salute, and everybody who has heard me talk about it knows that I believe that if we didn't have it, we would need to invent it. One thing that the GFF has really the potential for is to be focused on that financing the life course. With you, Rajat, with Agnes, with Joy Pumapi, we also publish a commentary of this special series that Mary, we appreciate very much you and the team putting out. And one of the things that we noted, and also you resorted in your presentation, is that the key part of that life course, namely the adolescent years, is a gap. It's mentioned in the investment cases, but when you look at really what are the investments that are happening, what are the programs that are being supported, this is significant gap, and we have the fortune to have really look with us. One thing that we are all hoping to hear more look is the result of the Adolescent Lab, the analysis and the investments that were geared to translate the adolescent programs into reality. This is one thing that we absolutely is a must, and we need to look at, not to lose investment in the early year of life, but to maximize that for this generation and the next generation. Now, the other aspect that we need to really strengthen is not just adolescents as a target and recipients of financing for their adolescent-friendly services, but also, Mary mentioned it, you mentioned it also, Luke, the participation, the meaningful participation of adolescent and youth in the definition of the national priorities, of the national program, of the national investment, and very important, on the accountability for where do those resources are. I mean, we are all watching a world where Gen Z is the voice for accountability of the resources, and we need to have that engagement very loud and clear. Then finally, because time is very short, I hope that we will have an additional webinar just focus on these aspects. Currently, as development assistance is shrinking, there is one aspect of overall development that is not shrinking, which is the financing for climate change. When it comes to health adaptation, health mitigation, we managed to make the case that climate change has a tremendous impact on the health, especially on the health of women, children, and adolescents. But yet, we have not managed to make the case that financing should come from those very same instruments that are designed to address climate change impact. For example, the Green Climate Fund, 2 years ago, has opened a window for accessing funds for health adaptation. And yet, very few countries have access to that window of grants because countries don't know how to access those resources. And there is what we call that intersectoral battle for control of resources. So the Minister of Environment protect their space for the Green Climate Fund, and they keep the Ministry of Health on the side. So I really hope, Rajat, that we can have, PMNCH can be a vehicle for the conversation of how do we make the case and how do we make it happen that some of the resources that are currently going into the financing for climate change adaptation also address health and also address women, children, and adolescent health. Let me stop here, and thank you so much for this rich conversation.
Thank you for that, Flavia. Much appreciate that clarity, and also much appreciate all you making the links to co-financing models, linking in financing for women and children's health with other sectoral priorities such as climate change, nutrition, and elsewhere. And I know we are out of time. There is a plethora of questions which I'm sure I cannot do justice to, and I will not. But there are two I would like to really come back to. Luke, if I may have a brief reaction from you, if it is possible, 1 minute or less. There are two questions. One is with regards to GFF's role in addressing the debt crisis that most LMICs face. And I know you have some thoughts. We have talked about it previously as well. And any brief reflections on innovative co-financing models, something that Flavia alluded to as well, that GFF is considering or we might want to. And Mary, if I could come to you very briefly of any learnings from the series on financing in health workforce. We had a very important comment in terms of financing in midwifery issues, but there are other health workforce issues. And I know, having gone through the series, that there are some important observations there. So any short reflections, Mary, or you could even point to the relevant paper if you want. Luke, first to you and then to Mary.
Big questions in a minute, but I'll be brief. So on the debt crisis, and it's not to, I mean, maybe to start by saying that this is a really serious crisis. We recognize that. We we see the impact of it. I wanted to clarify, though, the link that we have with IDA and what that means in terms of debt management. So we work through the World Bank systems, and the World Bank engages with country on debt sustainability analysis, and there are caps that they don't cross if, on loans, but also, and therefore a strong focus on the sustainability there. There's also work on restructuring, etc. But also important to understand that the poorest countries, and the poorer a country is, the less of its IDA allocation comes in the form of a loan. So it comes, some have only grants, some have grants and loans, and some have only loans in the IDA. And then they start to blend with IBRD. And so the terms get higher and higher based on their level of income. And so I wanted to emphasize that, but also maybe, and again, it's not to downplay the importance of the challenge, but the IDA allocation, the way it is, the IDA is some of the least expensive money available, and countries will borrow, and they will allocate that pot that they get, that envelope. And so I think we have, a role, we should have a role to play in encouraging them to allocate for health, but also using it really well so that they get the return in, whatever number of years. So it's a more complex issue than that, but I'll stop there for that one. On innovative co-financing models, it's also a very large question, but just to say that, the GFF itself was innovative when it started, and we're tweaking also how it works. So for example, looking at, and this is part of the strategy development process, it might be that we land there or not, but one idea is to say, do we increase the size of the grant somewhat if a country really shows a lot of leadership on alignment, and that they get, so an incentive there. But the other big area which people usually think about is how do we incentivize the private sector? And there we've had some experience working with the International Finance Corporation part of the bank, where we help structure public-private partnerships in Côte d'Ivoire, for example, on diagnostics. The value we add is that with our incentive, as in reducing the cost to governments to working with IFC because they have to pay for those services, we insist on a focus on equity, a focus on reaching as poor as possible, because that's sometimes a challenge with private sector engagement. I'll stop there. There's a lot more to say, but I know we're really short on time. Thanks.
Thanks for laying that outlook. Mary?
Thanks. Really important question about midwives that I saw as well. So I've popped in the chat the 2 papers where we looked at maternal newborn health and quality. And midwife didn't come up very often. It was there a few times, but not consistently. And I think just important to note, we didn't look at human resources for health as a theme. And I do think that it would be something for future work to look at. The paper that Joël led on community did, though, look at how kind of community health was framed in these documents, and found that the investments themselves centered on, community health workers. But I think there was limited support for kind of wider engagement and how that, played in, because oftentimes these documents, they only have a little bit of a glimpse of what this broader project is going to be doing as well. So just to caveat that we didn't look at it, but we did come across it in our searches. Thanks.
Thanks for that, Mary. And colleagues, thank you to all of you for staying. We started with roughly around 300 plus participants on this call. We still have about 200 with us. And that just shows not just the importance of this conversation, but to each and every one of you, your commitment to addressing these issues. My sincere thanks to all the panelists for their openness and their thoughtfulness in addressing these issues. These are challenging issues. Nobody has a magical playbook here, but what I do appreciate is the thoughtfulness with which we come. And Dr. Solomon, you are still here with us. I do have to say, one of the things that you said right at the start of our conversation, which is very critical, is moving forward will require not just political will, but leadership. And leadership, not just from political leaders, but from each and every one of us, because this is not going to be easy. Colleagues have outlined different models, investment strategies, approaches that can help us move forward. But as Anya Sukat rightly said, it's not just about more money. It's about how we use that money and how we galvanize sustainability of the resources that we are talking about. Because our ultimate accountability is to those women, children, and adolescents that we hold so dear. Thank you for joining us. This is not the end of the conversation for us. This is a starting of a conversation. We are working with a sister initiative, the Global Leaders Network. There will be a set of 6 webinars which will be delving deeper into country strategies and priorities and how they are accelerating resources for investing in women, children, and adolescents' health. Thank you, and also for staying for 10 minutes extra for all your time. Good luck. Hope you have a lovely rest of the day where you are. Thank you
so much,
Thank you.
Roger. Bye.
Thank you.
Yeah.
Thank you.
Bye-bye.